Okay, hi everybody. For those of you I have not yet met, my name is Camille Prejean and I'm a fourth year medical student at LSU and I'm applying opto this year. I've had the pleasure of spending the past eight weeks with you guys at LSU Ophthalmology, and today I'm gonna be doing my grand rounds on a patient that I met in clinic. So here's just the disclosure. Please remember to fill out the evaluation at the end of the presentation, and let's get started. Okay, so HPI. We have a 63-year-old African-American woman referred by optometry to general ophthalmology for blurry vision and an abnormal fundus exam. Past ocular history, non-visually significant cataracts bilaterally, presbyopia, and she's also a glaucoma suspect. She's really not taking any drops other than over-the-counter artificial tears as needed for her dry eyes. She has no family history, and her only allergy is penicillin. Her visual acuity is 20/30, pinholing 20/25 bilaterally. Her intraocular pressure is 19 on the right, 20 on the left. Pupil, she had a normal pupil exam, full confrontation visual fields, and her extraocular movements were full in ortho. Slit lamp exam was pretty normal as well. The only notable things on slit lamp exam were arcus bilaterally, 2+ nuclear sclerotic cataracts, and a Weiss ring on the right side in the vitreous. And here are her fundus photos, right and left respectively.
Can one of the first years or the second years describe the fundus photo in the right and the left eye?
Chris. Oh, okay.
Okay. For the right eye's color fundus photo, media looks clear. The disc margins look sharp. Can't really appreciate the cup to disc ratio. The macula, there are multiple hyper-reflective white lesions in the parafoveal area, also involving the fovea. But the rest of the macula looks flat. The visualized periphery looks flat, and the vessels look normal. And on the image to the left, the color fundus photo, media clear. The disc looks pink and sharp with about a 0.4 cup to disc ratio. Macula looks flat, and the vessels look normal, and the visualized periphery looks normal.
Okay. Thank you, John. Really good job. This is what we have. Disc, we saw a thin temporal rim bilaterally. Cup to disc ratio on the right was 0.45, on the left was 0.4. Macula, they do look kind of white, but we describe them as golden refractile crystalline deposits clustered parafoveally, as you said. Then everything else looks pretty normal. Okay, next, here are her visual fields. So she had full visual fields in her right eye. And then you can see one defect infratemporal to fixation in the left eye, but otherwise her visual fields are pretty full.
And just FYI, this is Dr. Rao. It's a really good study. There were no fixation losses, so it's as reliable as a study could be.
Thank you. Okay, and here is the optic nerve head and RNFL for our patient. And you can see here that her optic nerve looks pretty healthy. There's really no optic nerve swelling, and you really can't see any crystals on the optic nerve. Next, here is her MAC OCT, and here is the enlarged MAC OCT. And here you can see that there are no intraretinal or subretinal fluid bilaterally. Okay, so does anybody have any ideas for a differential diagnosis of this crystalline retinopathy?
Could get tamoxifen,
Okay, really good.
calc, Is um,
What about anything hereditary? Any inherited diseases, genetic diseases?
Yeti.
Just-
Urea.
Okay, that's awesome. Does anybody else have anything? Okay, well, I kind of divided up the differential diagnosis in a couple of different categories. So first, I have genetic diseases. So a lot of these were already mentioned, like primary hyperoxaluria, cystinosis, Sjögren-Larsen syndrome, and then there's Biety's crystalline dystrophy, and there's also Pagellan syndrome. I have asterisks next to Sjögren-Larsen and Pagellan just because both of these diseases present with spasticity, which our patient did not have, but I just thought it was an interesting pearl. Next, we have drug-induced causes, and a lot of these were mentioned also. So there's canthaxanthin, tamoxifen, anastrozole, talc, nitrofurantoin, methoxyflurane, triamcinolone, and ganciclovir. And then I have the others category, which is calcified drusen, calciphylaxis, also known as calcific uremic arteriolopathy, West African crystalline retinopathy, and then there's also macular telangiectasia type 2. Okay, so next, here's just kind of going over some of the genetic crystalline retinopathies and what they look like. So this one that we have here is Sjögren-Larsen syndrome. And you can see that there are white, yellow parafoveal crystals. Next, this one is Biety's, and you can see yellow, white crystals in the macula and in the mid-periphery. Next, we have primary hyperoxaluria, and here you can see yellow crystals in the center of black subretinal ringlets in the macula. I'm really sorry if you can hear a cat meowing in the background. My cat decided to come downstairs and she will not stop meowing. Okay, so next, here are some drug-induced crystalline retinopathies. This one is canthaxanthin. You can see tiny golden crystals in an annular parafoveal distribution. This one is talc. You can see small yellow intra-arteriolar retinal crystals. And this one is tamoxifen, which is the fine golden, highly refractile parafoveal crystals. So to me, a lot of those crystalline retinopathies looked very, very similar. And so a really helpful way to distinguish crystalline retinopathies is with OCT. And you can use OCT to locate where in the retina the retinal deposits are located, and that can help to kind of hint you in on what crystalline retinopathy you're dealing with. So here's a chart. So talc, methoxyflurane, and calciphylaxis all kind of present themselves in the retinal vasculature, whereas tamoxifen, canthaxanthin, and Sjögren-Larsen syndrome show up in the inner retinal layers. Calcified drusen can show up in the outer retinal layers. And then Biety's and primary hyperoxaluria can show up diffusely throughout the retina. So back to our patient. Her past medical history is type 2 diabetes on insulin, hypothyroidism, hypertension and hyperlipidemia, chronic kidney disease, status post 2 kidney transplants and dialysis. Also a history of atypical ductal hyperplasia, status post lumpectomy and tamoxifen hormonal prevention that she completed in June of 2019. It's notable that she was taking 20 milligrams daily for 5 years of the tamoxifen. So in order to further characterize her crystalline retinopathy, we decided to order a 5-line raster since the MAC OCT didn't really show any crystals. So here's a 5-line raster of her right eye. And just a reminder, whenever we were looking at the fundus photos, the right eye is the one that we saw crystals in. So here we go. This is the first picture. We don't really see anything. Here's another one, still nothing. And then in this third picture, we start to see something. And I don't know if you can see with the yellow arrows, these little crystals right in the fovea on the inner retinal layers. This next photo also has them right here. They're very subtle, but there they are. Also in the inner retinal layers. And then nothing here. And these are just the inverted corresponding pictures with the 5-line raster photos that were showing crystals. So you can see in the inverted photos just these little tiny black dots. Here's a 5-line raster of the left eye. And as you can see, there really aren't any crystals seen there. Okay, so typical OCT findings of tamoxifen retinopathy are very similar to what our patient had. This isn't my patient, but these are some photos that I took from a study. And you can see here, the crystals are bilateral, but they're also located in the same area in the inner retinal layers. So the inner plexiform layers and the retinal nerve fibro layers. So tamoxifen ocular toxicity, the duration between the start of tamoxifen to obvious visual symptoms can vary from 2 to 5 years with a prevalence of 0.6% to 3.1%. And the effects on the eye are cumulative over time. 10 to 20 milligrams daily for 5 years is enough to cause ocular toxicity, but it's more common when the cumulative dose of tamoxifen exceeds 100 grams. Visual function and edema may improve after cessation of the drug, but it's important to note that the crystals can still remain in the retina even after tamoxifen is discontinued. So whenever we are talking about tamoxifen toxicity, it's important to remember that there's a spectrum of disease. So it can range from asymptomatic to very severe, causing CME with atrophic areas. Some of the ocular side effects of tamoxifen are crystalline retinopathy, cataracts, especially posterior subcapsular cataracts, vortex keratopathy, optic neuritis, pigmentary retinopathy, CME and atrophic areas. And you can treat the CME with oral acetazolamide, intravitreal anti-VEGF, or intravitreal triamcinolone injections. And here are some photos of crystalline retinopathy from another study. So the top left photo is just another picture of the fundus of a patient with tamoxifen retinopathy, and you can see those crystals. The top right photo is a fluorescein angiogram that shows CME from tamoxifen. And then the two bottom photos actually show cysts from tamoxifen. And you can see here that the cysts are also kind of presenting in the similar area that the crystals present. So some of the pathology and pathophysiology behind tamoxifen crystalline retinopathy. General pathology, it's important to note that the crystals stain positively for glycosaminoglycans. Some of the pathophys is that tamoxifen accumulates in lysosomes, and this leads to oxidative stress and retinal neuronal degeneration. Tamoxifen may also increase glutamate that can also cause axonal degeneration. And Mueller cell dysfunction may also be implicated. It's also interesting because Mueller cell dysfunction is also implicated in Sjogren-Larsen and MAC telangiectasia type 2. So tamoxifen crystalline retinopathy is most often bilateral, but unilateral cases have been reported. I couldn't really find online any type of specific percentage of unilateral versus bilateral cases, but I did find an interesting retrospective study in South Korea. They did it on 251 patients who took tamoxifen for at least 2 years at the same dose our patient was taking at 20 milligrams a day. And they found that 7.5% of patients had bilateral disease and 4.4% had unilateral disease. So just a little refresher on the mechanism of action of tamoxifen. It's a selective estrogen receptor modulator, or a SERM. Its anti-estrogenic properties on the mammary epithelium, so it's used for hormonal prevention against breast cancer. It has pro-estrogenic properties on the uterine epithelium, so it also increases the risk of endometrial carcinoma. And this figure on the right just kind of shows how tamoxifen works. So it just binds to the estrogen receptor on the breast cancer cell to prevent estrogen from binding to the estrogen receptor, and this just prevents the proliferation of breast cancer. Screening for tamoxifen crystalline retinopathy is interesting. So once the individual has been started on tamoxifen, they should have a baseline dilated eye exam within the first year of treatment. Asymptomatic patients should be followed every 4 to 6 months, while symptomatic patients should be seen every 3 months. According to the AAO, the presence of retinal deposits in the absence of visual symptoms actually does not warrant tamoxifen discontinuation. However, if there is loss of color vision, central vision loss, CME, or retinal hemorrhages, discontinuation of tamoxifen should be discussed with the patient's oncologist. The diagnosis and workup of tamoxifen crystalline retinopathy is actually pretty extensive. So first, you really want to get a good history to assess for risk factors, like a drug history, a genetic history. Then you also want to assess visual acuity, visual fields, color vision, and refraction. You also want to do fundoscopy to evaluate for the retinal deposits. For tamoxifen, you want to look for those golden refractile deposits in the parafoveal area. Then you want to do a spectral domain OCT to localize the crystalline deposits within the retinal layers. You can also do an ERG and look for decreased A wave and B wave in both scotopic and photopic measurements. That's kind of will hint you in that you're dealing with the tamoxifen retinopathy. You can also do fluorescein angiography to rule out macular edema, and fundus autofluorescence to evaluate for leakage and staining. So for our patient, the management and plan is we referred her to retina to follow the crystalline deposits because she came to a general ophthalmology clinic. Whenever she sees retina, they're going to conduct a full evaluation, including OCT, IVFA, color plates, and ERG if necessary, and they're going to assess for visually significant CME. And then she's going to follow up in general ophthalmology clinic in 6 months. Also, she is going to stop the tamoxifen and do not use it again, just because we don't want her crystals to continue to worsen. But what if a patient is still relying on tamoxifen for hormonal prevention against her breast cancer, but is also experiencing ocular toxicity from the drug? So she still has to take tamoxifen for breast cancer prophylaxis against breast cancer, but she also is starting to develop ocular symptoms. So what does a patient like that do? So according to the AAO, this patient should try raloxifene, also known as Evista. It is recommended by AAO as an alternative to tamoxifen for patients experiencing ocular side effects. It has a different chemical structure than tamoxifen, but it has the same anti-estrogenic properties on the mammary epithelium. So actually, tamoxifen has a triphenylethylene structure, whereas raloxifene has a benzothioprene structure, but they can both be used for hormonal prophylaxis against breast cancer. There have been fewer cases of uterine cancer and cataracts among patients who are using raloxifene compared to tamoxifen. The only downside is that raloxifene is a little more expensive than tamoxifen because raloxifene doesn't come in a generic form like tamoxifen does. Raloxifene just comes as Evista. Okay, are there any questions? These are my resources.
Hey, this is Zach. I was wondering, are the crystals made of the drug itself, or are they made of other material?
That's a really good question. So from what I found, the crystals are made up of like the degradation products of the lysosomes.
Okay, thanks.
Are there any other questions? Once
Just
again,
for the
really,
residents, the A wave is really the photoreceptor generated currents, and the B wave is really with the intraretinal cells. So if you have intraretinal cells and cysts, the B wave usually is more affected because that measures the potential of the intraretinal layers. But if you get photoreceptor toxicity, you can get A wave degradation also on the ERG. And I want to say Camille put all this together and she did a wonderful job. So I want to thank her.
thank you. Thank you. And thank you so much to Dr. Rao and Dr. Fernandez. They were a huge help. And once again, I'm really sorry if my cat was meowing a lot. This is like really good to know. I'll make sure to lock her up whenever virtual interviews kind of get going. But thank you guys for listening, and I hope you learned something from it.
Great presentation.
Thank you.
All right, I guess I'll go next. Let's see if I can share my screen. Can everyone see my screen?
Yeah.
Okay. So I'm at Williams. I'm a first-year ophthalmology resident. So my title is Quick Fix of the Urgent Care. I want to thank Dr. Aldejeli, Dr. Bernal, and Dr. Fernandez for helping me put this together. So here's the mandatory slides. Okay. So our patient was a 41-year-old African-American male with a past medical history of HIV, bipolar, and asthma. He came to the ED complaining of this like pruritic rash that started on his lower torso and then worked its way up to his upper extremities. It started 6 weeks before presentation. And then, he had subsequent left eye pain, photophobia, blurred vision that started 2 weeks prior to him presenting to the ED. And he also complained of these like white blotches moving around in his visual field. So a little quick backstory. He went to an urgent care in Florida about 1 week after the onset of the rash, and they treated him with steroids and Benadryl, which he said improved the rash for about a week or two, and then they returned. So when he presented, he came from Florida. He had just been released from prison back in January. HIV, we did not know his CD4 count. He said he was taking his heart therapy, thought his CD4 count was like above 300, but wasn't sure. Past ocular history, he denied. No allergies. And then, like I said, he was released from prison, came from Florida to New Orleans around 2 weeks before we saw him. And then he denied drug use and alcohol use. Let's see. So this is the rash that we saw whenever we saw him in the ED. So you can tell it's kind of a raised, like kind of erythematous rash over his arms. And then also, no real involvement of his palms per se. He does have a floss, I guess a dental flosser on his pinky. So I guess he keeps his teeth clean, but and then this is also the same rash along his torso. So kind of a dry, like the same raised, rash. So exam. So right eye pinhole to 20/20. Left eye, which is the eye he was complaining of with the photophobia and the pain, decreased vision, he was 2200. Got him down to 20/80. And then left eye, his pupil was 4 millimeters, was non-reactive. No APD, and the rest of the base exam was, unremarkable. So sweat lamp exam. So left eye, he had 1+ injection. He had notable ciliary flush. He had diffuse KPs. They were stellate KPs. In arch triangle, he had no epithelial defects that were seen with fluorescein staining, and then he had a mild AC reaction on 2+L, 3+ flare. Then he also had posterior synechiae that were basically going around his entire pupillary margin, except they spared around 2 to 3 o'clock. And then also there was some pigment on the anterior capsule. Dilated exam was unremarkable. So I guess differentials for somebody that comes in with a rash and then eye pain, throw some differentials out there, what you would kind of think of off the bat.
Syphilis, TB.
Drug-induced uveitis, some drug reaction.
Yep. So differential, just like anterior uveitis. So most of the time it's idiopathic, 50%. And then you also have infectious causes, which I'll name some of them: syphilis, TB, toxo, Lyme disease. And then you also have the inflammatory process, so that can cause it sarcoid, HLA. And then some of the other rare causes would be like lymphoma, leukemia, and then you can have, traumatic iritis, and then medication-induced, like y'all said as well. And then also, like, pertinent for him would be like immune recovery uveitis, depending on like when he started his heart therapy back. So workup. So it's important to just ask like other review systems besides just like eye symptoms. So any fever, skin rashes. Obviously, we saw a skin rash. And then you want to make sure, just because you see something in the anterior part of the eye, you want to make sure you do a thorough dilated eye exam to rule out any posterior involvement. And then, when somebody comes in with anterior uveitis, after you've ruled out any other involvement of the back of the eye, it's not always necessary to do a complete workup. So if it's their first episode of just a mild unilateral non-granulomatous anterior uveitis, and there's no evidence of any ongoing systemic disease, that patient can just be like seen in clinic. You don't have to do labs. You don't have to like investigate any further. If they have a known systemic disease or they're taking medications that are known to cause uveitis, you also don't have to do a lab workup. And then if they have particular findings that are like classic for a particular diagnosis, then you also don't have to do further lab workup. So for him though, he needed a lab workup with the rash, and obviously his HIV. We had to investigate it a little further. So these are just kind of the basic like labs that you would order for somebody with anterior uveitis. This is out of the Will's Eye Manual. You want to check for syphilis, TB, chest X-ray, and ACE for sarcoid. They suggest a Lyme antibody, which we'll talk about that a little further, and then HLA. So really, with all of these, you kind of want to use these labs based on your like clinical suspicion instead of just shotgunning labs trying to find a diagnosis based on positive lab results. So for him, his CD4 count was 332, and then when we got the Lyme antibody, so the immunoblot, which is the like screening, or actually the immunoblot is the Western blot, which is the confirmatory test. That was positive, as well as the ELISA for Lyme disease. And then the RPR titer was very high, and then also he had a positive antibody for syphilis. And then let's see. So basically, we're stuck with a patient with anterior uveitis, and he has positive serology for syphilis and Lyme disease. I guess the question is like, where do we kind of like go from here? So these are my learning objectives. So syphilis and Lyme disease, they're both caused by spirochetes. So syphilis is transmitted by direct contact with an infected lesion, as you know, most of the time a chancre. And then Lyme disease is transmitted by the tick. And they both had different stages of disease. So they both start off with like an early localized stage that usually is just a single skin lesion, which eventually evolves into a systemic disease with multiple other manifestations, including neurologic disease. And then they both have ocular manifestations that are most commonly seen in the secondary stage. So we're going to talk a little bit about syphilis first. So it's caused by Treponema pallidum. And like I said, it's transmitted by direct sexual contact with infectious lesions. And then also they have, congenital syphilis, which is vertically transferred through the placenta. It's known as a great masquerader. And then that's just a little picture of the spirochetes on dark field microscopy. So a little like history on syphilis. The first recorded outbreak was in Europe in 1495 during a French invasion in Italy. So they called it the French disease until 1530. During World War I, the French prostitutes who had syphilis actually charged higher rates for their services than healthy prostitutes, since soldiers with syphilis were not allowed on the front lines. So a little bit on the treatment. The first effective treatment was arsophenamine, which is an organoarsenic compound. It was discovered in 1907. And then in 1927, Julius Wagner Jauregg won the Nobel Prize for his discovery of pyrotherapy used to treat dementia paralytica, which is the term they basically used for neurosyphilis. So they would basically inoculate patients with Plasmodium vivax, which is one of the species that causes malaria, and they would basically induce prolonged high fevers in patients. And they said, at that time said that it cured syphilis. And then basically they had the quinine drugs back then before they had penicillin, and then they would just cure malaria after they had prolonged fevers. So today, syphilis infections are continuing to rise in the United States. According to the CDC in 2001, the national rate of primary and secondary syphilis was 2.1 per 100,000, which is the lowest rate since 1941, which is when penicillin came around. But since then, cases have continued to rise. There's a total of 30,000 cases of primary and secondary syphilis in the United States in 2017, and 12 million new cases per year in the world. So this is just kind of a map, 2017 from the CDC website. As you can see, Nevada has the highest rate, followed by California, and then Louisiana at number 3. And then in 2016, the CDC put out a clinical advisory in regards to ocular syphilis. They basically said that any patient with syphilis and ocular complaint should receive an immediate eye exam, and then also any patient that has syphilis and ocular complaint should also have CSF examined for neurosyphilis. And then they also said that ocular syphilis should be treated as neurosyphilis. So these are the stages of infection. So I won't go through this for too long, but primary stage, it's about 3 weeks after inoculation. You get that painless chancre, and it's highly infectious. That disappears, and then within weeks to months, you get secondary syphilis. It's kind of a systemic illness, fever, weight loss, and then that's the stage where you usually get the characteristic diffuse macular papular rash that usually involves the palms and soles. And then the eyes are affected in about 10% of cases. And then some people go on to the latent phase, which is basically asymptomatic patients, but with positive serologies. And then a few of those patients without treatment go into the tertiary stage, which is when you see neurosyphilis and cardiovascular manifestations of syphilis as well. So these are the screening recommendations for syphilis. Basically, they've kind of changed it up now. It used to start off with just screening tests, so like the VDRL, the RPR, which basically you can follow for treatment, and they're basically reflect the disease activity, but they also have a high rate of false positives. And then you have the confirmatory test, which is the FTA and the MHA. Those are positive for life. That shows that you have antibodies to syphilis. But now they're starting to kind of switch it up to where they recommend doing the confirmatory test first. So getting the FTA first. And if that's positive, then you can get the RPR, VDRL to kind of monitor disease activity. So ocular syphilis, so basically any stage of syphilis can affect the eye. It basically can infect any structure of the eye as well. This is the 2018 CDC case definition of ocular syphilis. So you have to have a positive treponemal and non-treponemal test. And then this just goes through like possible, likely, and verified cases. So basically, in order to get a verified case of ocular syphilis, they say that you have to have PCR testing or dark field microscopy of aqueous or vitreous fluid that shows, the spirochetes in there, or the positive PCR, which I think is very rare that somebody is going to get an aqueous sample to test for syphilis, but thought that was interesting. So these are just the ocular manifestations. I mean, you can see they can affect any structure of the eye. So yeah, and it's just important to keep in mind that a lot of these are different when you compare congenital syphilis to acquired syphilis. But you can get, chancres on the orbit, eyelids, and then conjunctivitis, scleritis. You can get interstitial keratitis, and then neurological. You can get, cranial nerve palsies. I mean, basically anything that you can think of, syphilis can manifest as. And then in regards to syphilitic uveitis, so it's the most common ocular presentation, usually seen around 6 weeks after the primary infection, which is about the same time that the secondary stage starts. And this is the reported incidence. So usually the most common is granulomatous uveitis, anterior uveitis, and then that's followed by non-granulomatous, and then panuveitis, and then keratouveitis. And then in patients with HIV, panuveitis is the most common. And then patients without HIV, posterior uveitis is the most common. And then that's just that picture shows iris rosseolae, which is a pretty specific finding for syphilis. Pretty rare, but if you see it, it's pretty specific. Posterior involvement. So this is a picture of something you can see that's pretty unique to panuveitis caused by syphilis. So you get these small, like creamy white superficial retinal precipitates, and eventually they become like confluent. And then also you can have this associated with like vasculitis and also vascular occlusions. And then you can also just have a pure retinitis component, which is also pretty rare. It can be necrotizing or non-necrotizing. And it's important to, think about other causes as like porn and ARN, which can both present pretty similarly, but the retinitis caused by syphilis responds pretty rapidly to penicillin treatment, which the other ones would not. And then also these lesions tend to heal without damaging the underlying RP. So this is another like rare entity that's pretty specific also to syphilis, acute syphilitic posterior placoid chorioretinitis. So you get these large placoid yellowish lesions in the retina. They can be centered around the macula. They can also be found in the periphery. And they're not really sure exactly what the cause is. Some people have speculated that it's direct invasion of the choriocapillaris by the spirochetes themselves. And then also they have speculated that it's just deposition of immune complexes. And then on fluorescein angiography with these, you'll get the characteristic like leopard spot changes is how they describe it. And that can help you distinguish it from similar entities. And you can see in this picture, the large like placoid yellowish lesion of ASPPC. So optic disc involvement, you can get anything from optic nerve pallor, you can get optic nerve like guma, perineuritis, or optic neuritis. So there's no specific finding that is going to point you in the direction of syphilis causing optic neuritis versus other causes. But it is important to differentiate between perineuritis and optic neuritis, just because perineuritis has a more mild course versus optic neuritis, which can be like rapidly progressive with very severe visual loss. So the best way to kind of differentiate these is with the MRI. You can see like the difference in enhancement of like the optic nerve sheath versus the actual optic nerve in these, and I have a picture to represent that. So this is perineuritis. You can see the picture on the left, kind of what they call the donut sign. You can see where the nerve sheath is the structure that's enhancing. versus optic neuritis, where you see the whole optic nerve itself with increased enhancement. So management, so any patient that comes in with syphilis and has eye clear findings, like we said earlier, you want to get a lumbar puncture, even if they're not having any neurological symptoms. And, you know, like I said earlier, a patient with syphilis that has ocular complaints is going to be treated with, you know, the regimen for neurosyphilis. So just, you know, doing this lumbar puncture is not really to change management. It's more so you can follow the CSF studies through the course of treatment if they do have positive CSF studies for syphilis. So the lab criteria for neurosyphilis: positive FTA in the serum, and then a positive CSF VDRL. But having a negative CSF VDRL does not rule out neurosyphilis though. So people have like come up with other criteria for neurosyphilis based on CSF studies, and they say, you know, having more than 5 lymphocytes in the CSF or increased protein can also be used, but it's not a reliable criteria for patients with HIV, since at baseline they can have increased protein and lymphocytes. So treatment for ocular syphilis, you're going to treat it like neurosyphilis. So aqueous crystalline penicillin G, about 4 million units every 4 hours, and you're going to do that for about 2 weeks. And then also there's alternative therapy. You can just do the penicillin G intramuscular injections followed by probenecid for also 2 weeks. And then, you know, you want to monitor treatment based on the serum RPR titer. You want to see about a 4-fold decrease in the titer. And then, like I said earlier, if CSF shows, you know, findings like the positive VDRL, then you want to keep monitoring with repeated like LPs about every 6 months for 2 years. And then the majority of cases, the ocular complaints like resolve pretty much completely with proper treatment of syphilis with penicillin, but you can get some long-term sequelae just from, you know, steroid drops treating the uveitis or just the chronic inflammation, so cataracts, glaucoma, epiretinal membrane. You can also get macular edema. And then, so to go on talking about Lyme disease, so like I said, it's also caused by a spirochete. It's transferred by a tick, mostly found in the Northeast United States. So it starts off with a characteristic bullseye rash at the site of like the tick inoculation. And then stage 2 is also characterized by, you know, the systemic symptoms, fever, flu-like illness. And then you can also get like it's pretty rare, but you can also get like a full-blown like rash that covers your torso. I mean, it can be all over your body, called erythema chronicum migrans. So instead of just that bullseye rash at that one site, you can get the rash like all over your body as well. And then stage 3 is when you get like the arthritis, encephalopathy, and neurological disease. So yeah, approximately 30,000 cases are reported in the United States a year. And for the diagnosis, the CDC recommends a 2-tier approach. Also kind of like syphilis, you get the ELISA screening test. And then if that is positive or indeterminate, then you confirm that test with Western blot testing. So some of the ocular involvement, you know, stage 1, the most common finding is just follicular conjunctivitis. Stage 2, uveitis, and then you can get optic neuritis, papilledema. And then stage 3, you'll see like a stromal keratitis, and it's usually both eyes. And this is the Lyme disease distribution for the CDC. So as you can see, like the Northeast United States has the highest, you know, incidence of Lyme disease. So our guy, he came from Florida to Louisiana. So in 2018, the incidence in Florida was 0.5 per 100,000. And then Louisiana, it was 0 per 100,000. So it's basically non-existent in the southern United States. Let's see. And this brings us to like the diagnostic algorithm. So, you know, before you just start ordering tests, you obviously want to base each test that you order based on like your clinical suspicion, like we said earlier. So start off with a pretest probability. So for our guy, looking back, his pretest probability for having Lyme disease is very low, definitely less than 20%. So honestly, like from this algorithm, testing for Lyme disease was probably not indicated, but we did test for Lyme disease, and it came back positive. Like we saw, his screening test came back positive, and then his confirmatory Western blot also came back positive. So we're going to talk about that in just a minute. So treatment though for Lyme disease, the recommended antibiotic is doxycycline, but also as an alternative in the BCSC book, you can use penicillin G, pretty much at the same dose and duration as the penicillin recommended for neurosyphilis. So our patient, July 7th, when he presented to the ED, we diagnosed him with the anterior uveitis and started him on Pred Forte and atropine. Labs came back whenever he presented to clinic 3 days later. Spoke with the infectious disease doctors. They told him to go to the ED for admission to have a PICC line placed. He stayed in the hospital for, I guess, like 4 days, had penicillin treatment. And then we saw him upon discharge on the 24th, and basically he was having improvement in his AC reaction, and we continued the Pred Forte and atropine, and we have not seen him since then. So basically, the question is, like with our patient, we're thinking syphilis for sure as the cause for his ocular complaints, but he does have a positive Lyme serology. So, do we just ignore the Lyme test that came back positive, or, what do we do? So, we question the cross-reactivity of syphilis and Lyme disease. They're both spirochetes. So I found this article, and it's basically a study they did in Nova Scotia. So they investigated the previous reports of false positive Lyme disease screening results as a consequence of current syphilis infection. So they took 30 samples of serologically confirmed syphilis patients, and they tested them for Lyme disease with the screening test. So the ELISA screening, and let's see, any Lyme screening test that came back positive or indeterminate, then they sent off to another lab to have the confirmatory Western blot testing done. So the way that they defined confirmed syphilis was having a positive TPSA, TPPA, or CMIA, which is the confirmatory test, and whether they had a positive or negative RPR, they really didn't regard that. And then confirmed Lyme disease, it was done with a Western blot, which basically, if it had 5 out of 10 bands for IgG, it was considered confirmed. And then for IgM, it was 2 out of 3 bands. So this are the results of the study. So they start out with 30 of the syphilis confirmed serum samples. And when you look up here at the positive under IgM, IgG, ELISA, so the number of samples that tested positive for Lyme screening were 19 out of 30. And then when you go down here to the bottom, so they took those 19 positive screening Lyme disease samples and sent them to the national lab and did the Western blot, and none of those came back with positive Western blot results. So basically from this study, they show that like you can have cross-reactivity in a patient that has syphilis with the screening test for Lyme disease, but you should not have any cross-reactivity with the Western blot. But with our guy, on his testing, he had the positive ELISA for Lyme disease, but then with the Western blot, the criteria were 5 out of 10 bands. He had 7 out of 10 bands on his Western blot testing. So according to this study, he had confirmed Lyme disease, and also the labs that we use, their criteria is also 5 out of 10. So also according to them, he also did have Lyme disease. So we were kind of stuck in the dilemma of, what do we do with this? But after like researching it more in with with the penicillin for syphilis, since the penicillin dose that he's receiving is alternative therapy for Lyme disease. But I guess the dilemma here is, I think a lot of times we just get these labs and just like shotgun approach the patient and try to figure out what's going on based on positive labs. If you look back at that algorithm that I showed you for Lyme disease testing, if we just sat there and thought about it, his pre-test probability for Lyme disease was very low. It was pointing more towards syphilis. So, looking back, probably should not have ordered the Lyme disease testing, like we said, because it just kind of like confuses the picture now. So I guess it's something to keep in mind if they do continue to treat him, if he ever shows back up to the hospital and his symptoms have not improved. I guess it, is something to keep in the back of our head that maybe he does have Lyme disease, and maybe we need to, run that down a little further and see if that could be what's causing all of this. But questions or comments?
Interesting case.
Thank you.
This is Dr. Barron. Why do they call syphilis syphilis?
I know I read about that, but I'm drawing blank right now.
Nicole, are you there?
Yes, and I know I answered this a while ago, but now I'm forgetting to.
Does anyone remember? There was a poem written, and syphilis was a shepherd. And syphilis made fun of the sun god because the sun god was shining a lot of heat on him, and that was the sun god's revenge. So syphilis got its name strictly from this shepherd in this poem, which was written in 1530, which you indicated.
Wow.
All syphilis has been called the great pox as opposed to smallpox. So I think the pictures that you showed at the beginning are very illustrative of the great pox.
As well as the great imposter, right?
Yes.
There used to be a neuro-ophthalmologist at Bascom Palmer who was pretty famous and gave a lot of lectures and did tapes before it was popular to do tapes. And he thought everyone had syphilis because it had such a huge variety of manifestations. And sometimes he was right. They did have syphilis.
So I was wondering, I agree this was an interesting case. I would be tempted to get a Lyme disease test on any patient that had a rash with like a uveitis, sort of like this patient did. I don't know what our staff would recommend in that.
Lyme is so rare, Martina. I usually don't get it unless my other testing comes back negative. At that point, then I do instead of testing with like the more rare stuff, but I usually go with the most common things, especially because especially here in Louisiana, it's so rare. I mean, of course, if the patient tells you they were, I don't know, northeast, in the woods, then yes. But if they don't have the history that goes with it, then it's just so rare that I usually don't ask for it.
Makes sense.
Has it not been,
I agree.
Rarely reported in Texas? I thought there were some animals in Texas that they found to have it. Pretty unusual, but still.
Yeah, I agree also. And I don't know the exact prevalence and incidence in the last couple of years, but I've heard it's gotten up. In you're seeing it in places where you didn't used to see it before. I usually don't order it unless a patient tells me that they think there's a possibility they have had a tick bite.
Yeah, I don't know about the Texas thing. Otherwise, I'm not sure.
Yeah, and Dr. Bernal, the patient that I sent to you that had a positive FTA, but the RPR was negative, and he had a chronic uveitis, you recommended testing for Lyme because there was a questionable history of a tick bite. It came back positive. I think he had 5 out of 10 bands. He was admitted to the hospital, treated for Lyme, and we saw him today, and he's done very well. Has hardly any inflammation.
Oh, good to know. Thank you.
one thing is true is any patient that has recurrent uveitis, especially with posterior, you have to check syphilis on all of them, syphilis and TB, especially before you started them on any therapy other than topical steroids. Absolutely have to rule it out.
So with the benefit of the internet, I'm seeing there's 50 to 275 human cases of Lyme disease in Texas annually. This is from 2019. So very unusual, but it can occur.
Great presentation, Matthew.
Thank you.
Now we can take bite in Texas. We need to look for Lyme too. There you go. Good job, Matt.